Welcome to Courtney on Health, heard exclusively on MalcolmPresents.com, which is a new streaming service producing its own half-hour programming and soon to produce smaller time slots for people who can't concentrate for a half hour. But anyway,
Well, we can concentrate here for a half hour because we have good material by an incredible host.
we could do a few hours because Courtney has so much information that she could,
Right.
People might get sick of me though.
That's right.
Anyway, give us the intro, Max.
Let's get rolling. So, okay, without further ado, so hi, Courtney again, and hi,
Hello.
Malcolm out in the left coast there. Welcome to Courtney on Health, a Zoomcast podcast series which focuses on one's overall well-being. And there's tips on nutrition and exercise given by the wonderful Courtney Gravenese, who's a registered dietitian with a Master of Science degree in nutrition and applied physiology. Courtney is an experienced nutritional and health consultant in the New York metro area and beyond into the universe of universes, and will help guide you on a path to wellness and health. So this is a topic that is coming up. It's sort of in the radar, but under the radar a bit. But parents, you're always trying to feed your kids. Parents have to deal with a lot when raising a child, and they hope that their kiddo is a good quote unquote eater. You hope you get a kid who just will be showing gusto for food, but a lot of that doesn't happen all the time. So what happens when your child has little interest in eating food and has a very limited variety of preferred foods? Chances are the child has ARFID, which is Avoidant Restrictive Food Intake Disorder. And it's a fairly new eating disorder and can lead to poor growth, poor health, improper nutrition, fear and anxiety about food or the consequence of eating, like choking, can lead to ARFID. Is not the same as being a picky eater. Many times children, as well as adults, avoid foods that have an unwanted color, taste, texture, or smell. And there is kind of a mental health component to this, and the sensory aversions and fears regarding food. Treatment can take the form of cognitive behavioral therapy. There's a lot to cover regarding this RFID, and Courtney will take us through treatment options, how it is diagnosed, and what parents and caregivers can do to help their child. So
Max, RFID is what again?
ARFID. AFRID. ARFID.
Yeah, FID.
Avoidant Restrictive Food Intake Disorder. I know, it's a mouthful. So we're just going to call it
ARFID. ARFID, it sounds almost like, come here, ARFID.
I know. But all I know it has a bizarre name, but for either adults, experiencing this themselves, or a caregiver or a parent struggling with a child who's experiencing this, it's certainly more than humorous to them. So although more common now than certainly it was before, let's just say pre-COVID, it's still not all that common. Really only about between 3 to 5% of the total population has, and again, the diagnoses can be a little tricky, right? Because although it is definitely considered an eating disorder, it's one type of eating disorder. So there's a chance that some ARFID cases are getting blended in with that mix, but nonetheless, they're estimating about 3 to 5% of total population, and a portion of that, about 20%, is among school-aged children. So there are some resources out there. I hope to really get this out to parents, because it's important that they realize that they don't need to try and figure this out on their own. And there is you mentioned this, Maxine, but it's important to mention this is really well beyond the picky eater, right? So I deal with picky eaters all of the time. And quite frankly, it is a rite of passage for many, many kids, almost every kid. So this is a little bit different than the kid who snubs his or her nose up at, whatever, fill in the blank, meatloaf, some pasta that's a new sauce. This is really, again, it's a type of eating disorder beyond pickiness. It's when a child is extremely selective about the food that they're eating, or shows very little interest in the foods that they're eating. And I'm going to give you an example. It might be
Excuse me,
only
one clarification. You say school age. What ages does that include?
So that's pretty much up through high school. So, but younger. So think kindergarten really through middle school is when it is diagnosed most frequently. And this is specifically ARFID. We're not talking about other eating disorders like anorexia, different. So for this population, younger. So think K through middle school.
Right.
Yeah. So thank you.
Yeah,
for bringing that
it's
up.
definitely something I hear more about with even, you know, people I know with their young kids, and they only want to eat chicken nuggets if they eat anything. You know, that's all they want to eat. They only want to eat rice. You know, they'll just go for one food. So how do you pick? Continue what you're saying. How do you pick up what the radar, you know, that you have to have to see what the problem is?
Right. So finicky/picky eater might be, maybe they'll only eat chicken nuggets, but they're going to eat a decent variety of other stuff. They'll eat a couple of fruits. They'll eat a couple of veg. They'll have pizza. They'll have, again, it might not be very broad, but it's broad enough for a young kiddo. That's a finicky/picky eater. The ARFID child might be even more excessive than that in their restriction, in that it might only be one vegetable and maybe pasta, and that's it. That is it. And within those categories, the vegetable has to be prepared one certain way, or the pasta has to be prepared one certain way, no variation whatsoever. Again, it's a little hard to tease out, but I'll give you a couple of more things, you know, to look for. So it usually begins at a younger age, and more often than not, at least at this point, it appears to be more common in boys than it does in young girls. That may be due to the fact, because one of the populations of folks where we see this is in individuals, kids with ADHD and possibly on the autism spectrum. So if you look at that population of kiddos, there is a higher percentage of those, a greater prevalence of those conditions among boys than among girls. So at this point, and this can always change, but at this point, it appears to be more prevalent among boys, young boys.
Yeah, when you were talking about their preference of food, it almost reminded me, as you said, the autistic, because you see the autistic, they want one thing, one way. And that's what you were describing.
Right, that's right. So these kiddos are typically going to fall into either one or more of the following categories. So it could be a fear of, and you touched on this, Maxine, in your opening, a fear of a physical response that they either are apprehensive about happening, or it has happened in the past. And what I mean by that is maybe at some point they had a choking experience somewhere along the way, and they are attaching every experience to that past experience, and they're fearful. So maybe that's part of it. Or maybe they've gotten sick in the past, they vomited, and they're attaching future experiences with that past experience. Low interest or the lack of joy of eating, or low appetite. Now we've all, I mean, you know, chances are people who are listening, either they themselves have either kids or nieces or somebody they've known. Kids have a certain joy of eating, even if it's not necessarily the healthiest stuff.
Ice cream, yay.
Right. So looking for a cue like that your child has really little to no interest in eating, or there's no joy in whatever it is that they are eating. And then there might be sensory objectives. And what I mean by that is it's not uncommon to have a child referred to sort of as a sensory child, meaning that there might be smells, tastes, specific textures, colors of foods that they find particularly objectionable. So, you know, a big category, it's called food neophobia, which literally is just a big fancy word for somebody who's afraid of trying new foods. So they know their comfort level of a specific food, and they're going to stick with that. So again, it could be one of those characteristics, or it could be some combination of those characteristics.
Yeah,
I know
Kristen,
people like people who don't like strawberries, I know as adults, they don't like the feel, the texture, or tomatoes. And the weird thing about tomatoes is they won't eat tomatoes, but they'll eat ketchup. They'll eat, sauce,
Right.
but not the actual tomato. Never kind of got that.
Right.
So,
Does this have anything to do with environmental? That if for some reason, like if your parents like this food or are good eaters, would would that make the child be good eaters, or would that, or the parents who are good eaters, they have the child with this affliction?
Well, I will say, and before, because I'm always very, very careful about saying anything that's going to make a parent feel like, oh my gosh, I've done this to my kiddo. And first of all, I want you to exhale, take a deep breath. Chances are this had nothing to do with what you've done as a parent. We do have lots of data to suggest that kids who are raised in an environment of healthy nutrition and exercise habits, their parents are offering, or the caregivers are offering, a wide variety of foods. There's a healthy, perspective on weight. So not too much, not too little, sort of that sweet spot that's down there. Those children tend to have, a more robust diet. But that's not to say that even those kiddos could have ARFID as well. But so we don't really know the causes, Malcolm, but it's a little unclear. But there is apparently there can be a genetic component. There can be. It could have to do with the child's personality. Is the child particularly anxious? Are they experiencing some OCD? So there's possibly a link there. Again, back to that choking example. Was there a history of choking that maybe hasn't been quite teased out yet that they are hanging on to? Allergies, GERDs, which is gastric esophageal reflux disease. So if you think about it, if you have a response to eating a certain food because of an allergy, well, I don't blame a kiddo for wanting to say, I'm not eating that, nor am I eating anything that's like that. So that's one of the possible causes. Same thing with GERDs. GERDs can cause tremendous discomfort in both adults and children. And sometimes children just don't have the language to communicate that uncomfortable feeling. But if there's a group of foods that are causing this reflux and they're avoiding them, well, that may be a cause. So you can see there's lots of possibilities, which as a parent, you'd be like, great, I don't really know which one this is, but it might help you narrow down the possible causes so that you can work as a team, with your, and I'm going to talk about what that team should look like when you're looking for help.
Right. So what about food insecurity, and like if you're in a family that has the religious fasting occurs, and a kiddo's going to see that, or unfortunately, if there's a lot of kids going hungry right here, and right. I mean, is it? I don't think we can hit that much on a social component, but that could lead to something like this.
Well, it may, but currently the data doesn't support that. So you have to keep in mind that fasting, when I mean fasting, let's use your example of religious fasting, no matter what religion it is, we actually have the contrary data that suggests that, in terms of spirituality, that type of fasting, which supports the spirituality, actually has beneficial components to it as opposed to negative components. And I just don't know if we have the data at this point to say those kiddos who are experiencing food insecurity are at any greater risk of ARFID than those kids who are food secure. We just don't. It may be. We just don't have the data yet.
Right. There's a lot that has to be looked at. Just a question: who's going to notice this? Who's treating ARFID? Mm-hmm. When you notice this and you see that there's a problem, and then you go to, I guess, pediatrician would be your first line. But then where does it go from there? And you mentioned a
Sure.
neurologist, it could be
Sure.
GERD.
No, thank you for bringing that up, because it's so important that parents understand that they should not go this alone. That they need a supportive team. So I think if you as a parent are observing something beyond, again, so separate out, my kiddo doesn't have the best diet, couple of fruits, maybe one veg, but for the most part, there's like, at least 10 to a dozen things that he or she is eating. But still, but really drill that down to the specifics we just mentioned. You observe that as a parent. First line would clearly be the pediatrician. Now he or she may firstly say, let's take a look at some of the statistics that we have. Let's take a look at weight. Let's take a height. It's not uncommon to take a look at the curve, which, remember, you can be, and just a reminder, for parents, if you've got a little kiddo who's been on the 2nd percentile their entire from birth, you don't expect is that low? Sure, it's low, but it's normal for your kiddo, and that is absolutely fine. What you're looking for and what a pediatrician is looking for are big swings in either direction. And in the case of ARFID, because they're so restricted in intake, kiddos will drop off of their curve, potentially. So they may look at that. They may do blood screening there to see if there are any vitamin and mineral deficiencies because of this highly restrictive diet. So pediatrician is always going to be, I think, the first part of that team. So he or she may then recommend a gastroenterologist to pursue different testing. So let's take a look and see if there's something, pathophysiologically that we might be missing. They can check for GERDs, they can check for obstruction, they can, a speech language pathologist can check for things that might be triggering choking in your child. So a speech language pathologist may be part of that team for sure. A dietitian who is, once the diagnosis has been made, working with a dietitian who is especially trained in eating disorders, and a physician for that matter, is going to be key. And I think many dietitians are great, but there are different wheelhouses, and you really want somebody who's highly specialized in eating disorders, and not all of the dietitians are.
Yeah. How long should you observe the child before you get worried? Because I know, like with my kids, every 2 months is a different change of something they don't like, or they like, or they
Right.
eat. But how long should you observe this behavior before you should consult a physician or worry?
Well, gosh, I am always from the camp, Malcolm, that if you are a worried parent, you pick up the phone and you start with that phone call, and then let somebody pull you in from the ledge. And don't diagnose this on your own, because it can't be diagnosed on your own. So I think if you're worried, then seek some help. So that answer can be a day for a parent, which is a little unrealistic. Or it can be, I'm observing this over the last several weeks or months. What's happening? This is not typical for my child. That, I say, would be a conversation that would be a starting point, I would say. And then, before I forget, because this is so important, the last part of that healthcare team, and some would argue the key component, is a therapist. You mentioned CBT,
Right.
Maxine. It is very, very important that become part of it, because there is going to be, in all likelihood, part of this that is what's going on, what's making you feel this way, and and having the proper therapies to work through that is going to be absolutely key.
Yeah, looks like that's an important part of this as well. To figure out what's causing this from a level that could be in your head, in your head. So
Right.
that's a
Right,
whole,
which by the way, even if it is,
Mhm.
this is okay, right? Then
Sure.
that doesn't mean it's in your head, but it means that we need somebody highly skilled in order to, and parents, I see this a lot. When it's getting better in this country, our perspective on mental health, but it's a bit of a taboo, and it has been for years. So parents don't necessarily want to go to that room, right? My child is having perhaps some significant struggles, and we need to seek out mental, sort of therapies to help with mental health. and please, hopefully we're moving past that. And that needs to be part of the team and view it in a very different way. You wouldn't withhold that kind of treatment. If somebody were a diabetic, you wouldn't say, don't take your insulin. So don't take your fill in the blank, whatever the therapist, the mental health specialist is recommending. So look at it that way, please.
So
what
are the risk factors now on this? I mean, how is it affecting the body? And it also affects adults too, I believe.
Sure.
Even though it's mostly in kids.
Yeah.
So what risk factors? What can we talk about it?
No, thanks for bringing that up, because many would say, well, okay, so what's the big deal? So, it doesn't eat for, except if you separate out adults from children are in that incredible growth phase when they're even before kindergarten. So we do see poor growth, secondary to things like just low protein intake, low calorie intake, vitamin and mineral deficiencies, delayed puberty in some cases. The lack of adequate nutrition can lead to poor energy levels, dizziness, dehydration, muscle weakness, and osteoporosis, so weakened bones. We've spoken about this on our shows before, that incredible window for your bones to get super strong for the remainder of your life is childhood up until about late 20s. So you don't want to miss out on that window. And this is, of course, what the data is saying, is that these kiddos, unfortunately, are at greater risk for that, the weaker bones than a kiddo who's not as restrictive. And of course, amenorrhea, not getting your period, there's the delayed puberty. So in young women, the lack of either getting a period or sort of irregular periods can occur.
Right. Is there any, in terms of those who are treating it, I wonder what their range, if there's any medications that help with it. Is there anything that'll help with appetite? Is there anything that'll help, anything that the parent could grab on that might work?
Well, let me first target those things that parents can absolutely do and should do. And let me bookmark the Medicaid. I want to stay in my lane. You guys know that I'm not a physician, so I try not to, if there's known data, I'll talk about it. But those are really best questions addressed to a healthcare provider, either your pediatrician or psychiatrist, psychologist, who has a better understanding of potential medications that may help, side effects, and things like that. But certainly there's things that parents and caregivers can do. So if you're not home and you have somebody helping out at home, certainly this information can be passed on to him or her. The most obvious is be as supportive and as encouraging and with positive attitudes about nutrition and exercise. And this really does mean for parents to really try and curtail as much as you can food shaming, body shaming. This is not about weight. In fact, in cases of ARFID, it is not about weight. We don't, although we do see perhaps a decreased weight, the reasons why there's this highly restrictive behavior is not because they're trying to get, in quotes, skinny. It is different reasons, which of course separates this from things like anorexia. So nice positive attitudes towards both fitness and nutrition. Being a positive role model, we talk about this all the time. Now, I get it. Parents are busy. So the idea of eating family dinners every single night all together and having this incredible, display of foods might not be possible all the time, but to the best that you can, you want to be that positive role model of you yourself eating, a decent variety of foods. Praise when they try something new. So lots of praise, and you should encourage variety as much as possible. I see a lot of parents sometimes with even just the finicky eater. Kid only likes chicken nuggets. Let's use your example, Maxine. So all that kiddo gets offered, because nobody wants a battle, is chicken nuggets. So parents don't want to rock the boat. I totally get it. I'm a parent too, but you should, as best you can, offer more variety, at least put it onto the plate. Praise, lots of praise when the child does try something new. Praise for the healthy foods. If your kiddo normally eats, pie is, and and tries ice cream or, cookies, just being neutral about that. I mean, yes, that's a new food. So neutral for that, high praise for trying something new, and certainly never force, and never make a child feel badly about not trying something new. There's nothing to gain with that. So high praise for trying, neutrality when it is something that's maybe not necessarily going to add to their vitamin and mineral content. Careful with that catering of to the same foods all the time, and then regular meal times is so very, very important. And then along with that, if you feel like your child is experiencing some anxiety, some techniques to manage stress before they're about to eat a meal. So it could be something as simple deep breathing, positive visualization, anything to help bring down that heart rate, create more of a sense of calm before they're about to eat, does wonders. And those are just two examples, but anything, again, your child best. So tap into what he or she really finds enjoyable, and try that technique for stress management around mealtime. And then I highly recommend the National Eating Disorders Association for tools for parents, for resources for parents. Again, that's the national. I'll put it in the when I post
put it on.
this.
Yeah, when you
National.
post, put it up. Yeah.
Yep.
I'll tell you,
And then if you're looking for a dietitian who specializes in eating disorders, you're going to want to go to the eatright.org, which is the website for the Academy of Nutrition and Dietetics, dietitians, and you're going to seek out in your state, in your area, those dietitians who specialize in eating disorders.
Yeah, the more you're talking, the more I wonder how I survived my kids growing up, because there's so many. I'm a natural warrior. I say something, I see a symptom. Oh my God, what do I do? So you're talking about stress. How much stress does that put on parents?
Sure, a lot. There's a very scientific number for you. A lot. So it is a lot, because like I said, it's like, what am I doing? What did I do wrong? And
what did I do wrong?
Nothing you did wrong. There isn't. And again, I want to make sure because I don't want every parent going like, oh my gosh, this is really separate out highly restrictive, like fewer than like a half a dozen foods. And I hate to even put a number on it, from a kiddo who's eaten enough, growing okay, gets enough in, but maybe doesn't eat, a wide, huge variety of veg. So, and start there, start with your pediatrician, get that team together to help give you the support you need to support your kiddo.
Have they done a sociological study about the kids who suffer from this? Or are they rich, poor, or are they African American, or they Latino, or are they white, or are they,
I don't have that information in front of me. I do wonder, because remember, it's a relatively new subcategory of eating disorders. So it might not be available yet, but that would be certainly interesting to see. My instinct on this, if we look at percentages of individuals with eating disorders, the big broad umbrella, that tends to be mostly among, so not lower socioeconomic, more affluent populations. Historically, it's been mostly among Caucasian individuals. And although once really all girls and women, we're seeing the numbers climb up in men now as well.
Wow, that brings me to the Mikey Likes It. We did that episode of Mikey Likes It. No, I guess one is Mikey Doesn't Like It in this one. I don't know. This should be the Mikey Doesn't Like It episode.
But sometimes I object to some of the commercials. Like there's a big one on now about a guy with his daughter and food on the food line, and he can't afford certain things. But then he has this credit card that gives him money. And then they'll say, okay, we won't put the broccoli back on. All the good food they won't put back on.
Oh, well, I don't know. That's a whole different thing. So, is there anything else you need to kind of throw in before we wrap? Or
no, I feel like I threw so much, but if there was help, Know that there's support. Know you're not in this alone, nor should you be expected to do this alone. You know, again, I'll post some of these resources so you have them available to you.
Right.
And, you know, seek out the help when you need it.
Especially
So-
that, was it
Now, do
eatright.org?
you think the local pediatrician would be knowledgeable in this?
Absolutely. I think I think your pediatrician is always and should be your first line to now. That's not to say that I got to do a shout out to schools, you know, particularly, you know, solid school districts. And let's hope there are more of those than necessarily not. But many times it could be your school psychologist who's picking up on this, the school nurse. I feel like the school nurse has been like the rock star.
Yeah.
So it's possible
Absolutely.
that you know, he or she's picking up on something that, you know, again, parents are busy, maybe they got 4 kids and it's just getting missed. So don't rule out the school support that might be available, particularly in terms of, you know, a flag that might be there. But yeah, I do believe pediatricians are the first place to certainly start for the diagnosis and to help you work through it.
Okay,
We have to give a shout out to the school nurses and school psychologists, because boy, they really do a fabulous job, and they have to keep track of so many kids, and then luckily I, you know, been luck would have that the terrific people here in this district over the years have been very helpful.
Okay, Max, we have to wrap up.
Okay, I'm wrapping up. All right. So here we go. Thanks for joining us for Courtney on Health. To get more info, follow Courtney on her Facebook page, which is Courtney on Health, on Instagram at CLG Wellness, which is also her TikTok handle. Visit her website, CourtneyGravenese.com. For past shows, you can go to MalcolmPresents.com and theManyShadesOfGreen.com. You can also find the podcasts on your favorite podcast apps. So it's been Courtney on Health, smart, sound nutrition, strong, safe fitness, and we will catch you again next time.
See you
See you next week. Bye.
Bye.